So, welcome again in the third part of the Bacteriophage Therapy part, where I shall be speaking about the acute traumatic wounds, not chronic wound, versus the conventional therapy which is being done. And this study was conducted during 2018 to July 2020. And you can see the traumatic wound is great challenge to surgeons as it is large in size, heavily infected and pathetic. So you must have seen the road traffic wounds, and you can see I shall be showing you a few of the pictures later on, and you will find that you can appreciate that how dreaded these wounds are there. And once the bacteria are getting colonized and then they go to the chronic stage like biofilm formation, the amount of the very expensive antibiotics and the local as well as the systemic is not going to give any help to us. So that is the problem. uh, Infection may lead to function loss, amputation, chronic wound, septicemia, or even death. Majority of the traumatic wound prove to have polymicrobial infection because if somebody is lying on the road dust, so dust is having a lot of variety of the bacteria and they are usually multi-drug resistant as well. Sometimes pan-drug resistant. So bacteriophage therapy may revolutionize in the treatment of traumatic wound. So let us see that what is the role of the bacteriophage therapy. We conducted another clinical trial as a part of the Master of Surgery thesis with the collaboration of Surgery Department, and I'm showing you the findings. The study we undertook to look into the potential alternative of topical antimicrobial therapy for the treatment of acute infected traumatic wound and a solution to multi-drug resistant bacteria. This was a case control study. Patients aged 12 to 60 years with acute traumatic wounds were taken into this study at Trauma Center of Banaras Indian University. Customized bacteriophages were applied over the wound in case while the serial debridement and dressing with systemic antibiotics were given in the control. So a total of 54 patients met the clinical criteria, 27 in case group and 27 in control group. Wound swab and tissue biopsy was taken for the wound from the wound for bacterial isolation. Specific phase was isolated for case group which was applied over the wound on alternate day till the wound becomes sterile and divide of graft eating bacteria. So because if you have to go the skin grafting SSG, that is called as superficial skin grafting, for the large wound only, then it heals. So until unless this is sterile, the surface area is sterile, the skin graft will not be accepted by the host. So this is why you have to make the wound surface sterile. So this is one picture where conventional therapy is being given, means the cleaning of the wound, debridement with the alcohol and the povidone iodine, and then systemic antibiotics are being given. And you can see in this case, when we did the culture from this surface after 20, this you can see this is 2/8/2020, this is 8/8/2020, and this is 21/8/20. There is no sign of healing, and we could isolate the same bacteria of the first day to this day also. So the bacteria were all the time. It means if we are not treating, we cannot go for the skin grafting. The skin graft will be rejected. So this is another control. You can see this is the sloughing. Cleaning has given some effect. There is healthy granulation tissue, but you can see again yellow slough dead debris is here. But and here also we could isolate the patient after conventional therapy. CT stands for conventional therapy. And you can see here is the case where we started the therapy. You can see this is like degloving injury. Whole wound's skin has been taken away. And then we started the treatment as soon as we got the bacteriophage against the isolated bacteria. And we started therapy, and you can see this on 6/9/18. So you can see this is almost 8-9 days only. Healthy granulation tissue has appeared, and then by the end of 12/9, you can see this is after 15 days. Complete healthy tissue is there, and this is fit for the case of SSG, superficial skin grafting. This will be healing very fast. This is another case. You can see here we started the therapy 8/5, 17/5 May, then 21st May and 29th May, almost 1 month or a bit less than 1 month, maybe 21, 24 days. Again, it has come to the healthy granulation tissue, and then we have gone for the SSG. You can see the skin graft has been put over the surface, and the patient healing process, you can see the skin is coming out at several places. This is third case, rapid shrinking of left below knee amputation wound. There was the amputation due to the accident done below knee, and this was infected. And after the use of the bacteriophage for 6 days, it became sterile. And you know, without skin grafting, the closure occurred spontaneously. So there was no need. The skin grew up like this, and there was a complete healing. So this is the beauty of the bacteriophage therapy we got. In conventional therapy, it takes very long, or sometimes, or usually don't heal. So let us see what happened. Showing the effect of the bacteriophage therapy in comparison to conventional therapy. Cases with the bacteriophage therapy, BT is bacteriophage and CT is the conventional therapy. This is skin grafting could be done in 74.1% of the cases, while in conventional therapy only 33.3% cases could SSGB could be done. Otherwise, it was not possible to go for this superficial skin grafting. Wound closure by second degree or third degree intervention. It means primary intention there is very minimal scarring or fibrous tissue formation. But if the closure is occurring by the second degree, third degree, a lot of fibrous tissue formation, contracture of the affected area occurs, and it was quite high in the conventional therapy and quite low, 18.5% in case of bacteriophage therapy. So again, it was very good here. The difference was 0.004. It means significantly better than this. Last follow up 3.7%, and there was one case was last in the follow up. There was one death due to certain other unrelated reason, and re-intervention in one case we had to do, and total the 27 cases were there. So full granular tissue, how many days, days taken by the full granular tissue formation, and you can see the control mean day was this. So full granular tissue in 15 days, and while this is in 23 days. So the difference is 8 days more are there, and this difference is significant. Final intervention we could do on 25th day on an average, while this was 43rd day. So again there is a huge difference, 5, 30, 10, almost 18 days later. This leads to the healing by the secondary intention or tertiary intention. So intervention was done earlier, and this difference is again very significant. Then shows days required to attain complete granulation and sterile wound. So sterile wound in case of our study, it came by 20 days, while in controls just double, it was 40 days on an average, plus minus 5 days. So again the difference was significant. So fast therapy led to the healing very fast. Then here you can see this is very important. I just wanted to show you that what is the effect on not only the quality of healing or the speed of healing, the average expenditure in the treatment of both groups. You have seen the large wounds there. So if we simply take the antibiotic during non-specific bacteriophage therapy, initial 4-5 days we are giving the bacteriophage therapy, because till this is the time taken for the development of customized bacteriophages, if that is not available in our library. So during that time we give the antibiotic therapy, and we don't know what bacteria is there. That takes time in isolation and sensitivity testing. So that cost is around 6,000 plus minus 3,000. This is the government rate, hospital rate. Average cost charges for dressing, alternate day dressing for 12 times plus phage plus person. This cost is very cheap. It is almost 12,000 plus minus 3,000. And then wage losses of a person who is affected, say he is staying there for 400 per day for 25 days, so that may be 10,000 rupees, and daily expenditure hospital stay of the patient, that may be 7,500. And so this is the average. The total goes to 38,500 plus minus 3,000. This is an estimate. This is not exact one, but you can see the total expenditure comes this by the time the patient is getting cured and he is relieved from the hospital faster, means in the just half of the time. While in control group, you can see Antibiotic is given for not less than 10 to 14 days. The cost goes 10 times more. 60,000, and usually high-end antibiotics are given. They are, say, 1,500 to 2,000 per vial. Three vials are given, 8 hourly injections are given for 10 to 14 days. So that becomes very expensive. This is the less estimate, it may be larger, and plus minus 20,000. Average cost charges for dressing, again, it is quite high. 45,000 because the duration is more. Here only it is 12 times. It is until unless it is becoming sterile. So this may be 45 times. Daily daily dressing charges, wage losses for 45 days. This goes to 18,000, and daily expenditure of hospital stay, say 300 per day, 45 days, 13,500. So total expenditure becomes roughly 1,36,500 plus minus 22,000. So this difference is significant, and you can see the patient is suffering by both way, quality of healing and expenditure and quality of life as well. So this is the, and sometimes because of the fibrosis or non-healing, then again you have to go for the some other therapy, and if contracture is formed, then you have to seek the help of a surgeon or plastic surgeon. That becomes additional expenditure to on the part of the patient. So we published this paper recently. I think it is in 2022. You can see in January, and still we are waiting for the citations. But this is very significant paper, and nobody has done in the world literature this type of work. And this is a great thing if the government or regulatory body permits us, so we can have this technology. And for this, we need to have the number of laboratory isolating the phages and using at each and every major tertiary level hospitals. So, what are the challenges? Emergence of phage-resistant bacteria during the therapy, toxicity of the phages, which I mentioned earlier, immune elimination, I mentioned earlier, and transfer of harmful genes through transaction, and ethical permission to use the phages as a drug. So these are the challenges. Addressing issues related to bacteriophage product manufacturing and characterization, the utility of the use of animal studies for the proof of concept, phage therapy is unclear at this time. So we are trying to have certain evidences so that we can convince the regulatory body in coming days, and to design early clinical trials that reliably assess product safety and tolerability are prerequisites for advancing development to trial designed to demonstrate effectiveness and assesses the clinical benefit. So before thanking you, one thing very important point I left because there is no one-to-one interaction. You might be thinking that how easy is to isolate the bacteriophages from the environmental sample. So I'd like to tell you, since you are the student of zoology and you know that you might be handling with the cell culture, cell lines, maybe primary cell lines or continuous cell lines, human cells. So like that, we have got the bacterial cell lines. The beauty is that without having the malignant transformation, these bacteria keep on multiplying. You simply have to change the bacterial host. You can have the fresh medium added to this and bacteria will keep on multiplying. So what we are doing is that we are making a lawn culture of the bacteria, and then we are waiting till the bacteria is coming to the log phase. So log phase usually is 4 to 5 hours for most of the gram-negative bacteria, but certain bacteria like Enterococcus faecalis or Staph aureus, they are having longer this doubling time, and this may range up to 8 to 10 hours. So when the bacteria comes in the log phase, what we are doing is that we are collecting the water sample, maybe sewer from the pond or from the hospital sewer system or river Ganges, and then we are treating this water sample 5 to 10 ml with the 1% chloroform, few drops only, waiting for 10 minutes. So what chloroform does is that it dissolves the lipid available in the cell wall, and then the bacteria is lysed, the viruses are coming out, and whatever bacteria are there, they are all killed. So only viruses are there. Since viruses are pure protein coat structure, they don't have the lipids, so they are not affected by this short exposure of the chloroform. So we are simply flooding over the solid log phase bacteria and then incubating overnight. Next day, if we are lucky, we can get the clear plaques there if the count is very high, bacteriophage count. If not, Then what we are doing is that we are putting the TMG or normal saline 3 to 5 ml on the 90 plate and taking the washout, treating it as a previous sewer water or river water, and then again centrifuging, removing the debris, collecting the supernatant, and to the supernatant we are again adding 1% chloroform, waiting for 10 minutes, preparing another log phase of the bacterial lawn and pouring here. So it is usually seen that by this time we are able to have the plaque formation after overnight incubation. Now, if the plaques are there, maybe they are of varying size. So then you can have to pick up each and every plaque with the variable shape and size and to propagate them separately to have the purified bacteriophages. The other thing I would like to tell you that how to purify the bacteria after lysis from the toxins including endotoxins. There are two ways. One is that you are using ultracentrifugation, cesium chloride or the sucrose gradient centrifugation. But we have seen that this is very long and tough process, and sometimes we found that the bacteriophages are distributed in all the layers of the this tube, centrifuge tube. So what we are doing is that we are taking the 20 nanometer membrane filters, not filters, rather membrane tubes, and then we are putting the, because the pore size is 20 nanometers and bacteriophages are usually more than 20 nanometers, usual 100 to 200 nanometer size. So the, and outside we are putting the PEG 6000 and also 2.5% sodium chloride. So outer side becomes hypertonic and the inner side is isotonic. So naturally the small molecules smaller than the bacteriophages are going out, and we are using the PBS twice just to wash out the bacteriophages again. And so after the end of two, three washings, we are left with the say not milky, rather a bit yellowish color, smelling like sewer bacteriophage concentrate, and which are usually having very minimal amount of the bacteriophages. And these bacteriophages can easily be used for the further basic studies like electron microscopy or for clinical use as well. So this is the how we do routinely. And for the preservation there are, if you are just scraping the bacterial plaque with the straight wire or with the loop and then inoculating in the peptone stab as we do for the bacteria, the virus remains surviving there along with the bacteria because they are in maybe in the lysogenic phase or maybe inside the bacterial cell. And then we had been able to isolate the live viruses from these stocks after 10 years even. And then the other thing I would like to tell you that you can preserve them in a lyophilized form or you can preserve them at minus 80 degrees centigrade. So these are the preservation method, and then purified stock should be well characterized. Phages should be with you, and you can just isolate the DNA or RNA of the phages, and it can be submitted for the whole genome sequencing. And we have done whole genome sequencing of many of the viruses at our laboratory. Thank you very much.